I can't tell you how needed that research is as an internist and practicing critical care physician. That is pain we experience every day, and it certainly impacts care. So I applaud her for her efforts. Our next speaker, I have the pleasure of introducing on a personal level. I am very thrilled to introduce Dr. Deborah Cook. She doesn't know that I'm here, that I'm wearing this hat today, but she's actually my personal mentor. She trained me in critical care medicine and certainly guided my career in so many immeasurable ways. She is such a humble and kind person. She actually visited me in Oakville several times over the last 10 or 15 years just to provide personal support. So I'm just shocked that I get to have the privilege of introducing her today. She is the 2022 Canada Gairdner Wightman Award for pioneering research that has developed and defined evidence-based critical care medicine in Canada and informing best practices around the world. Guilty admission, if I go to an ICU conference somewhere in the world, getting a lukewarm reception, I'll just drop, I know Dr. Cook, and the room changes. Trust me, I've used that one a few times. She's also the Distinguished University Professor of the Departments of Medicine and of Health Research Methods, Evidence and Impact at McMaster University, Fellow of the Canadian Academy of Health Sciences, Fellow of the Royal Society of Canada, Officer of the Order of Canada, and a critical care physician at St. Joseph's Healthcare in Hamilton. Thank you very much. It's my honor to introduce Dr. Cook.
Great to see Sunny here, and Anna, thanks for a beautiful presentation. Let me start by thanking the Gairdner Foundation, the committees, peer review, individuals, the board, all the folks, the staff who've helped to underscore the important role of science in society. And I wanted to reflect for a moment on the exhilarating week it has been as a scientist in our country, meeting high school students, parliamentarians, early career investigators, mid-career scientists, senior scientists, just talking about our shared quest for knowledge. I'm humbled to stand among all the amazing scientists being honored here today and receive this award myself on behalf of the staff and the students with whom I've had the honor of working, my clinical colleagues at the bedside, like Sunny, many across the country, and the collaborators and co-investigators who've helped to enrich my career. These are some of the female staff, scholars, students with whom I work in Hamilton. I was so delighted to grow up in part at McMaster University, where questioning was part of the way we do things, and where equity and diversity and inclusivity were in existence before those were even the EDI three-letter acronym. Eminence-based medicine was alive and well when I graduated, and we had the great fortune of David Sackett, who came from the University of Chicago, who told us all about clinical epidemiology and the power that it held to transform the way we practice by offering insights and ensuring that we would learn whatever we could about the basic and clinical investigations that were published that would hopefully inform our practice, not dictate what we do, but enlighten us. Gordon Guyatt was my amazing mentor who struck that special balance between challenging me and nurturing me. A tightrope to walk, and one that I've tried to do with other individuals who I've had the honor of mentoring. At McMaster, there were some amazing scientists. Roberta Bondar, neurologist, Canada's first female astronaut, and someone who I know has also inspired others. Roberta being out there with her meteoric career, pardon the pun, was, even though I didn't know her, a source of inspiration. And May Cohen, a University of Toronto graduate, who was big in labeling women's health and calling to attention women in science. So this was my home. I was interested, though, in a vulnerable group of patients, not those in a clinic, not those on the general wards, but those who were critically ill, individuals requiring basic or advanced life support, individuals on the brink of death every day, individuals requiring much more than a doctor to look after them, nurses, respiratory therapists, physiotherapists, occupational therapists, pharmacists and nutritionists, so many individuals, social workers and spiritual care clinicians. This was not a community in science as well developed as in the States, and I went to Stanford University. Welcome to the modern world of critical care medicine. Overwhelmed by technology, you'll see that it's difficult to identify a patient in the middle of this image. But the patient has been the inspiration for all of my work, the patient and the family, and that holds true for critical care clinical investigators across our country. We began in the mountains. Coming back from California for a weekend, a group of us got together in Alberta. We were funded with a massive grant from MRC, $1,500. Go ahead, knock yourself out, get together. How about forming a research group? We didn't know what to do with that money, so we rented a bus and some beer, and we drove into the mountains and discussed together how it was we were going to collaborate. We took some inspiration from the view, and we realized as a large country with a small number of individuals, it was going to be important to collaborate. We needed more rigorous studies. We needed larger studies, 200 patients, 1,000 patients. That was not enough. We wanted to collaborate coast to coast, and we had to develop more infrastructure, individuals who were actually skilled in how to enroll patients in observational studies and randomized clinical trials. We knew it was important to ensure the quintessential Canadian camaraderie, and we thought hard about our mission. Bold, simple, and empowering, to try to advance the care and improve the outcomes of critically ill children and adults. This was through not just clinical research, but excellent clinical research. And it was important back then, and we didn't need a multi-million-dollar company to come in and do visioning with us. We said, what are our values? Well, we obviously are going to value scientific creativity and integrity and ensure that what we do is clinically relevant. And we shortened that pipeline from the early days of laboratory-based and animal-based investigations to try to enhance the possibility that studies, when they're done, they would be ready to consider implementing very soon after completion. We were very clear on the need for collegial relations. We had a little mantra, check your ego at the door. Some people were left behind the door. And some joined us after they learned the way we do things. We were always keen to ensure we were accountable to each other. We critiqued each other's protocols. We wanted to be responsible to our whole community and be fiscally responsible, knowing how precious resources could not be squandered in the early days of a research group. We were talking last night about organizational culture in the business world and how all of us have affinities for certain cultures. Organizational culture could be defined loosely as how things are around here, the invisible forces that move people to act, to behave, to speak. And we're all part of different organizational cultures in our communities, our place of work, our home perhaps, places of faith, in our gyms. But the organizational culture that we wanted to be part of, and I personally was keen to create, was one that valued innovation and creativity, was always rational and strategic, was group-oriented, but was not rigid, hierarchical, sexist. And knowing that this organizational culture could take us far, I think those of us involved in the early days wanted to ensure we retained some of these values. So our first chair was Dr. Thomas Todd, a thoracic surgeon, who got us together in the feisty days when people were a little edgy about getting together. And I was so honored to be a two-term chair of the trials group, followed by a wonderful friend and colleague, Dr. John Marshall, here in Toronto, a trauma surgeon intensivist. Paul Hebert spent most of his time at the University of Ottawa, and Robert Fowler here in Toronto, who's been an incredible gift to critical care through the pandemic, and Dr. Kissa Menon in Toronto, a pediatric intensivist. So our organizational culture really helped to define how we do things. So I'm going to speak a moment about foundations of clinical programs. So because in a large community, when we had nowhere to go but up in terms of generating our knowledge, it wasn't one project. We weren't going to do one-off little projects. We had a lot to sort out in the field. We were able to create ideas, do a little bit of early design, but it was through the connections and the conversations that our projects really took roots. The design features were key. We debated, we discussed, we poked, we prodded, and this notion of discussion and honest reflection and sharing our views was fundamental and has still been fundamental to this day about our clinical research programs. I'm just going to give you one example, and this is about gastrointestinal bleeding from the proximal gut, basically the stomach. And it's a kind, stress bleeding, as it was called back then, was related to bleeding from the stomach, related to allegedly the thin lining of the gastric mucosa and impaired blood flow. And we had noted that in the early days, people who were critically ill tended to be having a lot of bleeding. It was quite frequent, it was often fatal. And in fact, our patients were sometimes receiving 2 different drugs to try to prevent this bleeding. And we thought that was a little bit odd. And this example of a research program shows how critical it is to not just jump in and do a trial, because we were all ready to go. We're going to do a randomized trial. Let's try to see, are antacids better than this other drug? So I thought that maybe we were ready to do that right away, but wisely, and upon reflection and discussion, we went ahead to do some additional preliminary pre-trial observational studies. So a prognosis study to try to identify what the risks of bleeding would be, what the incidence was, and actually come up with a definition. Turns out to be quite important. It's not live or die, it's what is bleeding that is clinically important. We went on to examine, does bleeding really matter? What's the attributable morbidity, mortality of bleeding? Is it something we should be concerned about in terms of prevention? And then, of course, before the trial, just re-estimating what the relative risk reduction might be if we were to do a trial. And we went on and did this large trial, but this preparatory work was a crucial lesson for our community about the need for observational studies in humans before we launch a trial. And this work was the foundation of our early success in New England Journal of Medicine, and the randomized trial likewise was in New England Journal of Medicine. And this was something that was very important to us to understand all the problems that can be averted if you carefully conduct observational studies to get all your ducks in a row before you launch an expensive RCT. And these are just some of the many lessons that we've taken forward for the Canadian Critical Care Trials Group. Interestingly, this randomized trial did show that the use of an antacid, at this time was ranitidine, was associated with a 50% lower bleeding rate than a weak base, this agent called sucralfate, which was widely used and is hardly ever used now. But there was also a suggestion of an increased risk of pneumonia in patients receiving this antacid, the so-called gastropulmonary route of infection. And after the trial, we further used the RCT database in an observational analysis kind of way to determine risk factors for pneumonia and understand the attributable morbidity and mortality for pneumonia. And this launched a whole other career of Darren Hyland, who took this forward in a diagnostic RCT, also published in New England Journal. So some of the messages from these integrated research programs that stayed with us included the idea of not one-off studies, which can be certainly super important, but as we've heard about this morning, the idea of the long view. And we had this agenda that could be rolled out and would give incremental bits of knowledge that would take us forward. And Katie also underscored that earlier. So we had lots of questions. We needed to have methodologic advances because a lot of the critical care literature, modest as it was in patients, was not all that rigorous. And our funding was scarce. So we began to understand we need to harmonize. Everyone can have different ideas, that's great, but let's make sure we synergize around questions. We don't necessarily prioritize what we do, but we try to energize from getting together and make sure we mobilize as a community to be clear we can conduct what we set out to conduct. Second brief example I wanted to review is about blood clots. I'm sure everyone's familiar with blood clots in the legs or arms, sometimes the pelvis, which can break off and cause blood clots in the lung. And for those patients who are critically ill on mechanical ventilation, they have poor cardiopulmonary reserve. And a blood clot going to the lung in that instance can be potentially serious, not to mention hard to diagnose. So knowledge generation is key to critical care research in Canada, but so is faithful, timely knowledge translation. And that can involve applying the results of our research, but can also, and sometimes must, be associated with deprescribing and omitting practices that we thought were suitable. So the triad for blood clots is stasis, associated with immobilization, and obviously critically ill patients are super sick in bed, often heavily sedated, sometimes paralyzed, especially in the era of COVID. Vessel wall injury, because inserted catheters, peripheral, central, dialysis catheters, ECMO catheters, this is very, very common. And critical illness, this is a pro-inflammatory, procoagulant state. So it's like a perfect storm for blood clots. So like all good scientists, when we were beginning, we thought, all right, let's do an environmental scan. What's written about blood clots for critically ill patients? So we looked to some of the practice guidelines populating the literature. I was shocked that medical surgical ICU patients were not even mentioned anywhere. So, as you know, when there are holes in the literature, this is one of the good signals work needs to be done. And we embarked on another big program, but the first that I wanted to point out was the way in which Canadians reached out very early to do international collaborations. And this was a simple comparison between colleagues in France and Canada. There was the standard unfractionated heparin, and then the newer, more potent, and slightly more expensive low molecular weight heparin. And you can see the self-reported utilization confirmed when we observed what happened in an audit, completely disparate practices, which is, again, another good sign of, oh my gosh, this needs to be studied properly. So we went on with colleagues, not in France at this time, but Australians, investigators in the US, the UK, and Brazil to do the PROTECT study, and in fact, tested the low molecular weight versus unfractionated heparin comparison. And once again, the idea was, let's go, let's do this trial. No. We have more work to do. And we were so grateful to work with our translational biologists because there was some discussion amongst our colleagues about how there could be prothrombotic markers like factor V Leiden, prothrombin mutations. Some of these measures in the blood could be excellent predictors of blood clots, and perhaps we should be doing some genetic testing and try to identify a high risk and potentially responsive population to enroll. And that turned out not to be as fruitful, but was a crucial part of the journey. So very much later, after PROTECT was done, we thought, all right, what are the results and how are we going to translate them into practice? So the primary outcome was deep vein thrombosis of the leg, diagnosed by ultrasonography twice weekly. And you can see there that the hazard ratio, if it's 1, would indicate no difference one way or the other. And there was only a trend toward fewer blood clots in the legs. Pulmonary embolism, or PE, looked like a 50% reduction in PE, and no overall strong advantage in terms of reducing mortality, but HIT, the heparin allergy, seemed to be reduced about 50%. And importantly, no increased risk of bleeding in this higher risk, newer, allegedly more potent heparin. So what do we do with a study like that? Well, the people in France were saying, yeah, so you should be using it. And other folks are saying, yeah, but it's more expensive. Is it really all that much better? And we did go on with a number of other studies, but with the help of Rob Fowler and colleagues at Sunnybrook, we thought this again is a perfect situation where you're balancing all these things. And to recap, although the rates of DVT were similar, maybe slightly lower with low molecular weight heparin, certainly less PE and less HIT, the pulmonary embolism, the HIT, were very high morbidity, high mortality, and costly events, though rare. And it turned out that despite the cost differential in drug acquisition, when you cost out beyond the drug acquisition and think about the cost of these events, these clinical events in a trial, it was pretty clear that the low molecular weight heparin was a better way to go. And even then, they're just words. And we thought, what's going to speak to people in terms of knowledge translation? We've heard earlier about it's not just the individual practitioner, but their health policy implications. Other people are involved in which drug to use. And the analysis that we did identified that over a year, if there was a center that wanted to keep on using the unfractionated heparin, and they admitted 1,000 patients, they'd waste $1 million. Well, that caught everybody's attention. And so a lot of our work now in knowledge translation is trying to understand how to express what this might mean. And a lot of our work with patients and families made it pretty clear that everything that could be bad associated with these two different types of heparin was a similar probability or a lot less likely or a little bit less likely with the low molecular weight heparin. And so some of the family input was super helpful here. I want to end with one other example. As you know, Canadians want to largely die in the comfort of their home if they have a home, with family members if they have willing family members, if they can afford it, and if the situation is right. Most people die, most of us in this room will die in an institution of some kind, potentially, likely, technologically supported. Although life support can save lives, really, it just delays death. Death is still very common in the ICU, and I know all of you are well aware of that, having been through the COVID-19 pandemic. A good death, according to the World Health Organization, is a human right. That is not a reality for many places in the world. With our universal healthcare system in Canada, we hope that it could be a reality. We were interested in the early days in studying how people die in the ICU. And way before the pandemic, high proportions of patients were dying. Whether they came in with trauma or a surgical condition or medical condition, people were not really wanting to talk about it. And I recognized early on this was a place where there are numerous knowledge gaps And I remember few senior authorities in my world thought that this was really not a suitable area to study for a senior or junior scientist with any sort of credentials or brains. And I was actively discouraged from studying this. And in fact, one of my colleagues really wondered if it was ethical to study this. And I just felt sick hearing that. But I thought, it's unethical not to study this. This is how Canadians are passing away. And it was always a favorite focus of my practice and aspect of teaching. But we kind of put this theme on the slow burn, started involving nurses who are delivering the minute-to-minute daily care of critically ill patients, and involved several folks who were keen to take this forward, did a survey, and then did an observational study. And this was something that we wrote a grant for $400,000 from the Ontario government, and they awarded it, and only they awarded $40,000. So I remember writing to them saying, did you maybe forget the zero? Because it's 40,000 more. They said, no, and it was a clear message. This is not, this is not so important. But we went ahead. A lot of people volunteered their time and energy toward this, and starting with 851 mechanically ventilated patients. As you know, when the ventilator is weaned or people are liberated from the ventilator, they breathe on their own and hopefully live, but you can see that there's still a proportion who die in ICU, die in hospital, and go, there's some go home. Some people die on the ventilator, because they just don't get better. And then there are people who we withdraw from mechanical ventilation in anticipation of their death. And that might not be imminent, but it happens eventually, for the most part. But as you can see on the bottom there, we don't always get that prediction right. Some people anticipated to die actually leave hospital. And this was quite illuminating, sobering, you might say, and led us to wonder what the predictors are of this withdrawal of mechanical ventilation. I know everyone in our community and folks participated in this in Australia and in the US, thought it was going to be pre-ICU hospital features like old age, really sick, a lot of comorbidities. None of those were predictors. The predictors were the additional need for advanced life support, these medications which keep the heart rate up and the blood pressure up, and patients who are predicted to have a very low survival, which is largely a doctor's notion. And then people who were predicted by physicians largely to have impaired cognitive function, and then elicited from the family preferences. The family told us that these patients would be probably not wanting to live like this if they were going to survive. And this last notion helped to underscore the importance of the family input when we were discussing goals of care. And this was also the first time where we asked people to share their views about what their concerns were when people were on life support, often for days and days and seriously ill, because obviously many get better, but many do not. And this was the lens of ethics on end-of-life care, the uncomfortable lens of discussions of morality that were initially not welcome in the day. So what did we learn here? Engagement of the bedside staff was key, and we did surveys along the way to ask people's views. This really promoted some self-reflective practice, which was key, and because it was largely self-funded, it signaled to funders how important this was, and was a way to legitimize end-of-life research, if you will, and led to many conventional metrics of research success. So for this theme, if you will, the idea here of the passion of the topic, but your patience and waiting till the time is right to really launch a program was key, and persevering. And this led us to recently do a number of studies on something called the 3 Wishes Project. The overall objective was to try to improve the dying process so that in the fast-paced, technologically intense, dynamic, sterile setting of the ICU, It was possible to honor the inherent dignity of dying patients, humanize the dying process for family members and support them in grief, all those who are left behind, and then to try to inspire a deeper sense of vocation for the clinicians caring from them. And the idea was these terminal wishes could be anyone's wishes or preferences, the clinicians, the families, the patients, if they're able. And our hope was that this would bring comfort in the final days. Many wish categories exist: bringing in pets from home, playing music in the room, a taste of someone's favorite wine under the tongue, keepsakes, which have been very important in the pandemic, a number of different wishes. What is a wish, really, at the end of life? It is a process, it is a product, and a way to have a conversation starter for the individuals we care for. We often forget who are they before their critical illness and beyond their critical illness. These are some of the ways we conceptualize what is a wish in the 3 Wishes Project. We found through many multi-center studies with colleagues here in Toronto, Vancouver, UCLA, Brantford, Niagara, and a number of other cities in North America, as this has been taken up in a lot of different places, this approach to honoring the dying patient helps to recognize the inherent dignity in all human beings, gives voice to the family to try to create some memories, and calls forth clinician compassion, still a very important part of critical care. Fast forward to the pandemic, family members prohibited from being in the ICU. Covered up, so everyone looks like a Martian. Dying at these times, this was tough. We wondered, can the 3 Wishes Project help us? And we were ready. We found that clinicians were inspired to learn each patient's story, to try to advocate, step in where family or friends could not. The use of video conferencing technology, which has been used obviously everywhere, under appropriate circumstances can help to connect when people cannot be together and surrounded by the things and the people that they love. So amidst the challenges of providing personalized end-of-life care during the pandemic, clinicians were able to express their humanity and support patients and their families. So although in critical care we have more and more technology, we still need to figure out how to use it, in whom, when, and how long. Humanism has been at risk, attenuated sometimes, but we've always been keen to ensure that recognizing inherent dignity is maintained. And I'm now hopeful after the pandemic and all of our observations that humanism is alive and well, as is dignity-conserving care in critical care medicine in Canada and hopefully worldwide. Thank you so much.